Dr. Bill Wolf I have known for some time. A number of years ago, some of you remember Dr. Bob Murphy. He retired, and he'd been my doctor for a long time, and I was fishing around for a new doctor, and I was talking to people about names, and different animal names keep coming up. There's a bear, and there was a lobo, but this wolf name kept occurring. And so finally I managed an introduction, and it required great sales on my part to get him to accept my wife and I as patients, but it finally happened. So he was one of the leaders in the medical profession. He started Central Ohio Primary Care, and as you know, that kind of practice has now blossomed all over the country. He became their medical director, and recently he has become their CEO. He's an internist. He graduated from Ohio State and then got his doctorate up at Toledo Medical College of Ohio in Toledo, and then went into practice, had a private practice, and then became part of COPC and one of its developers. He's going to talk about, can we get value in life healthcare?
Thank you, Mr. French. This is my first Rotary meeting, and boy, this is a lesson. I mean, there are people running around with scissors. I should hide my tie. I've got to send a smoking cessation counselor to your golf outing. There's some things we didn't learn in medical school. One was never follow a really great prayer, so thank you for that. And never follow funny people. And so I don't know if I can make healthcare funny, but I'm going to try. My talk is, can we get to healthcare value? COPC, I'll tell you a little bit first about COPC, and then I'll tell you a little bit about what we're facing in healthcare going forward, and then I'll discuss a little bit of the programs we're putting in place to, I hope, create value in Central Ohio. I ask that you excuse my enthusiasm when I get to our programs. I'm going to sound like we have it all figured out. And so if you'll take my enthusiasm for what it is, and I present these things with humility. The truth is, we have stolen most of these ideas from organizations around the country. Some of them actually from Chad Evans at Mount Carmel, but we've been out to California several times where physicians have been at risk for years, in shared savings and at risk for years, and most everything we're doing, we've stolen their ideas. So COPC, we were founded in 1996. 33 of us got together, and for these reasons formed COPC. Paramount among that was the need to create a hospitalist program. Hospitalists are physicians that do not have a private practice. They only see patients in the hospital. We heard from, at that time, Riverside Hospital and Ohio Health, that our residents, we had residents working with us for 12 months a year. You had residents, house staff, interns taking care of your patients at night, and they notified us because of the changes in residency regulations that we would only have house staff 6 months a year. So it caused the doctors to get together and talk about how we would take care of each other's patients, and the answer to that was actually a hospitalist service. We also wanted better administrative services. In a small practice, I was in a practice of 5 physicians. In a small practice, your best medical assistant becomes your office manager, and oftentimes she or he is not at all prepared for that job. So we wanted a CEO and a CIO. We wanted all the O's. We also wanted to develop ancillary services. In 1996, physicians could own a laboratory, and we could bill for those services instead of using Quest or LabCorp. We could buy radiology equipment, and we could bill for a CAT scan or an MRI, and so we could own those services and increase our income. We wanted contracting leverage. If you're a group of 5 or 3 physicians, your contracts were just mailed to you. UHC would send you a contract for the next 3 years, and that was your rate, and you lived with it. But as 33 physicians, we could actually sit down with someone and negotiate. We also wanted to get to a single record, a common record, an electronic record, and that we felt that we could do better quality. We would have better quality parameters and guidance from a larger group. So that's why we formed COPC. Who are we today? COPC is the largest physician-owned primary care organization in the country. We have 300 physicians. Actually, since I made this slide 2 weeks ago, we now have 305 physicians. This is the time when residents are graduating and starting. By the end of September, we'll be up to about 320 physicians in COPC. You can see our breakdown. We're up to 70 hospitalists, which is very important to us. We have a few specialists, 20% pediatrics and 20% family medicine. We're on our second generation electronic health record. We're on eClinicalWorks, an electronic health record out of Boston. Includes a patient portal so we can contact our patients via a portal. We have 350,000 active patients in Central Ohio. We have 44 level 3 patient-centered medical homes. A little bit more on that later. Our laboratory is a high complexity laboratory. Our lab runs 3 shifts a day. It's off of Olentangy. And we take care of about 4,000 patients a day through our laboratory. We provide laboratory services for about 25 nursing homes here in Central Ohio. We have education programs that I'll discuss, high complexity radiology, CT, MRI, and physical therapy. Interesting thing about these profit centers back from 1996, the radiology and the cardiovascular and the laboratory, those are now, in a value equation, those are now cost centers. And fortunately for the employer and the patient, they actually cost less. So what used to be a value just because of the earnings now creates value for us in shared savings. So here are some of the problems going forward in healthcare. You all know this, and for those of you that run a business, you know we cannot sustain our cost trajectory. We're not getting value, and this is the definition of value. It's quality plus experience divided by cost. We're not getting value, and I'll have some slides to that. Fee for service, the old per-click healthcare is not patient-centered. And let me just address that for a minute. As far as our quality, we measure our physicians' quality. And it's based on multiple parameters. It's blood pressure control, diabetic control. Our highest quality physicians make the lowest amount of income because they spend the most time with patients. The problem with healthcare now is you cannot do it fast. And if you do it fast, you're probably not doing a good job. So fee-for-service medicine in a per-click environment is just no longer, it's not going to lead to quality. The other issue is by the time our physicians deal with think about being in an ACO, PQRS, which is physician quality reporting, meaningful use, which is the government telling us how to use our computers. But by the time we click enough boxes, our physicians are dissatisfied, and especially if they're living in this fee-for-service world. And so the way what we need to do to save primary care is to get our physicians, to have our physicians paid for events that don't happen. We need to say, this is our population, we will take care of them, we'll keep them out of the hospital, we'll take care of their chronic illness, we'll meet their needs, but we'll do that with the payer or the employer, but we need to share in the savings. And that's where we're headed in healthcare. So if you're a company moving to Ohio, or if you're a company moving from a state to another state, you're probably not going to choose Ohio. We pay more per capita than 33 other states. And when you look at the quality on the bottom, 29 states have higher quality. So you're probably not coming to Ohio if you're Boeing. Next, this is the next problem in healthcare. Look at the age graph. The population is exploding with people over 65. 10,000 Americans turn 65 every day and have done so for the last 5 years and will do so for the next 15 years. That's how we end up with this graph of people over 65. Remember, when Medicare was signed into law in the 60s, the average age was 67. Now it's 78. We can't kill patients. They live forever. So this is a problem going forward. The next problem, if we have a big population of elderly, where's the spend? And so you can see in Medicare, the top 25% of Medicare recipients account for 85% of the spend. The United States is actually an insurance company with an army. Look at where we spend 70% of our money: health, Social Security, and defense. We're an insurance company with an army. And so going forward, as we get older, our unfunded liabilities, we talk about a $19 trillion deficit. That's nothing compared to our unfunded liabilities for people turning 65. So let's also recognize the limitations of health care. You can see on this wheel that health care is 10% of health, just 10%. Genetics is 30%. Our decisions are 40%. Our socioeconomic status is 30%. We're only dealing in 10% of health in healthcare. But that's the area we're in, and that's what we'll address. So, Central Ohio Primary Care Population Health. We began with a patient-centered medical home program in 2011. And I'll discuss what that is in a minute. We expanded that in 2014 to also include just our Medicare Advantage population, and that's private Medicare. So we expanded that into that population of 20,000 patients, and to develop some tools to take better care of those 20,000 patients. We chose not to be an ACO, an MSSP, an ACO in the federal government, and we work very closely with the hospitals, and that's why I recognize Chad here from Mount Carmel. We meet every month with Mount Carmel, Ohio State, and Ohio Health. We tell them everything we are doing. Every program we're initiating, we are absolutely transparent with what we're trying to do in Central Ohio. And some people in our organization are, well, why do we share everything? Well, the truth is, we're all bad. We are doing a horrible, you saw the data. We are not doing a good job at taking care of Central Ohio. Why don't we start competing when we're doing a good job? So we are transparent, and fortunately, so are the systems. So 2011 was our PCMH initiative. This initiative, patient-centered medical home, is team-based care. This is everyone in an office, whether it's the person you greet at the front desk, whether it's the medical assistant, the physician, or the checkout person, has a role in your health care. We became certified. NCQA, the National Committee for Quality Assurance, certifies offices as patient-centered medical home, and we went through that process. We did it for two reasons. Number one, I'm going to grab my water if I can. This is my Marco Rubio. We did this actually for two reasons. Number one, we wanted to improve access. It was very important to us to improve access to our patients. In the past, 4 or 5 years ago, if you called one of our offices, your physician's schedule was full. They would squeeze you into a spot at lunch or in between patients, and they'd squeeze you in until they couldn't squeeze anybody else in. And that's fee for service. It's more clicks. That's good. But that isn't good patient care. So what we did was we asked let me jump ahead. We asked our physicians to open up their schedules, to leave same-day appointments, and to leave hospital follow-up appointments in their schedule. And since we control the schedules for the corporation, we were able to prove that that was done. We were able to do it for those that didn't want to. So we opened up access for patients. Because you know what happens after you've squeezed in a couple of people, where is everyone else going? They're going to urgent care, or they're going to the emergency room. They're going to a high-cost entity, and that entity does not have your outpatient record. So the doctor who takes care of you doesn't know anything about you, doesn't know your medications. They're depending on your memory for your 12 medicines. Secondly, instead of just opening access, we opened urgent cares for our patients. So for COPC patients, we have currently 3 urgent cares, two for adults, 1 for pediatric patients. Our third one opens in August. Again, improving access. In our same-day centers, if you call your primary care physician and they do not have an appointment available, all the same-day slots are full, they will actually plug you into the urgent care. So instead of saying, call the urgent care and get an appointment, they say you have an appointment at 7:30 at the urgent care. You show up at the urgent care, it's an appointment, you don't have to wait in line. A family physician with access to your record sees you, for an office copay. It's not an urgent care copay, and it's not an after-hours charge. They're open until 8 o'clock at night. The pediatric facility's open until 10 p.m., and they're open on weekends. So this is how we improved access. The second reason we became a PCMH was it allowed us to get our physicians on the same page around certain clinical goals. So you can see the conditions, but an example would be at the bottom, diabetes. We wanted our physicians to have a certain percent of their diabetics to goal and in control. If they were not to goal and not in control, that physician in the chart had to check a box, not to goal, and then had to complete a summary of what they were going to do to get the patient to goal and what the patient was going to do to get to goal. And so we could track this progress, and we did that for all of these conditions. We also expanded our education programs for our patients. We educate about 1,000 diabetics a year, COPC and non-COPC patients. It's an ADA certified education program. We have 11 classes per week. It's a 4-week series, 11 classes per week around the city. And what that's done is that's improved dramatically our numbers for diabetics in control. The national standard is to have 15% of your diabetics out of control. You're always going to have new patients or patients that aren't cooperative. And so the goal is to have 15% of your patients in control, and we consistently are less than 10%. We also expanded an asthma education program. This is actually for our children, for our pediatric offices. If you are a pediatric patient with asthma, you have an hour-and-a-half meeting with an asthma educator and a parent to learn about the disease, to learn to recognize an exacerbation in its early stages, and how to treat it. We were able to decrease ER utilization for our children, as well as steroid use and unplanned visits by 75%. We also have a smoking cessation class, which will be at the golf outing. This smoking cessation is interesting. If you're with the American Heart Association or the American Lung Association, they have classes for smoking cessation. The problem is they need 6 or 7 people in the class before they'll hold it. By the time they get number 6, one decided not to quit. They can't get a class. And so we'll educate 1 or 20 smokers, and we have a 4-week class. It's every Monday, twice on Monday. We also have a COPD, which is emphysema class. That's for people that missed the smoking cessation class. So in 2014, we decided to expand this initiative. And you can see what it included, and I'll go through these. We decided to expand this initiative around our Medicare Advantage population. And what we did was, in that population, we have shared savings contracts. So with Medigold, Anthem, Aetna, UHC, Humana, and Medical Mutual, we have shared savings arrangements around Medicare Advantage patients. If we come in under a certain performance level, we share in that savings. And there are quality gates. I mean, you can't create savings by withholding care. Now all of our commercial products also have these shared savings. So transition of care nursing. This program actually, and this is Medicare Advantage and commercial. If you're a COPC patient and you're admitted to one of 4 hospitals in Central Ohio, you will be greeted the following day by one of our nurses. One of our 14 transition nurses will sit at your bedside, tell you they're a COPC nurse, and they are going to manage your transition out of the hospital. What that means is, prior to discharge, they'll come back to the bedside and they'll set your primary care visit appointment before you leave. They'll pull up Dr. Staginski's schedule and put you in Tuesday at whatever time. And so instead of leaving the hospital with call your doctor for an appointment, you leave with an appointment. That nurse, that same nurse, then calls you 48 hours later and says, remember, Mrs. Smith, I hope there's not a Mrs. Smith in the room. Remember, Mrs. Smith, you've got an appointment Thursday. And, oh, by the way, did you fill your prescriptions? Did you stop your Lipitor and start your Zocor and reconcile medications? That nurse's job is done when that patient is seen. So she tracks that patient in the electronic record. And when that patient is seen by the primary care physician, she's done with her job. During the hospitalization, she's communicating with the primary care visit. She's sending notes within the record to the primary care physician about that hospitalization. What we've been able to do is decrease our readmission rate for Medicare Advantage to less than 7%. The national average is 19%. I would love to tell you it's all doctors. It's not. It's transition nurses. It is a nurse making sure that you keep your appointment. The difference between a patient who keeps their primary care appointment and one that does not is twofold. So if you've kept your appointment, that readmit rate is actually about 4 or 5%. If you've not, it's in 13, 14%. So that follow-up appointment is crucial. Visiting physicians. In 2014, we hired a visiting physician. This physician sees 2 patients per day. Pretty tough to make it in a fee-for-service world on 2 visits a day, but they see patients in their home. They see patients that are discharged from the hospital and can't or won't keep a follow-up appointment, or they see patients in crisis. So usually they have a scheduled appointment in the morning, and they get a call from an office saying, Betty Smith's sick. I think if we don't get to her house today, she's going to end up in the hospital. And we send a physician out to the home. You can see that we prevented 71 Medicare admissions, one physician, 71 Medicare admissions in 2 years. And you can see the total at about $10,800 a visit, or a Medicare admission. You can see the savings, and I promise you we didn't pay her that. This worked so effectively that we just hired our second visiting physician. Hospitalist services, I of course stressed this in the beginning, very important to us that when you are admitted to a hospital, you are seen by one of our partners. You're seen by a physician that has access to your outpatient chart. You're visited by one of our nurses, and that physician and that nurse are communicating back to your primary care physician while you're hospitalized. We thought it was so important that we expanded our hospitalist services from 2 hospitals where we are supported. And to address that, most hospitalist programs are supported by a hospital. A hospital provides a stipend so that you can actually be there at night, because you really can't make a living at night in a hospital. So we expanded to 4 hospitals on our own dime because we thought it was valuable enough. So right now, if you're admitted to Riverside, Dublin, St. Anne's, or Mount Carmel East, you're cared for by a COPC hospitalist who's one of our shareholders and also in shared savings. We also opened a 24-hour call center for our hospitalists, so all the calls from those hospitals go to one location and one physician and 2 nurses that are actually looking at 3 electronic health records, Ohio Health's, Mount Carmel's, and ours, and reconciling issues for those patients. Quality nurses. We have 5 quality nurses that sit behind the scene and close care gaps. So a care gap is your need for a mammography or a colonoscopy or an immunization. They bump up claims data from a payer, from an insurance company, against our electronic health record to see who's missing something. They'll reach out directly to the patient, they'll schedule tests, or they'll message the physician and say, Betty Smith's coming in tomorrow, and she hasn't had a mammogram. Please get that ordered. So, which patients are at the greatest risk? You saw a similar slide earlier, but this is also for commercial. 5% of patients account for 50% of the spend in healthcare. The second group is something that we'll also address, that 20%. In 2014, we started a care coordination program. This is a nurse and social worker team that takes care of those 5%. So how do we identify the 5%? If you are, and this program is just for Medicare Advantage currently, and that's not quite true, because if the right patient is, if we can help someone, we will, but it's limited mostly to that. If you are over 65 and you have been hospitalized, you're high risk. If you have been discharged with certain diagnoses, you're high risk, and actually we'll visit you in your home the next day if you have certain conditions that are high risk for readmission. But this, you can see the data here. We were able to decrease our readmission from 191 to 151 per thousand. Creates 400 admissions on 10,000 patients prevented with this initiative. So actually I should step back. If you told me that I had to stop something, one of these initiatives, I wouldn't know what to stop. Because again, we went out to different areas, we found out what people were doing, and we started them all at once. So if our CFO came and said, you have to get rid of a program, I'm not sure what I'd cut. But this has been very effective. And this is an RN and a social worker. Again, if need be, they'll come to your home, they'll assess your medical needs and your social needs to help you not be readmitted to the hospital. Rising risk population. This is the 20% of people below that 5%. That 20% of patients, very important to try to identify in that 20% who is next year's 5%, who is going to be high risk next year. So this rising risk population we identify as those diabetics out of control, patients with COPD, or actually kids with asthma. And we instead of the care coordinators, which are obviously expensive, instead of care coordinators, those are handed off to the office level. So we notify an office of who their 20% are, and they actually manage those patients. So a medical assistant may actually identify 10 diabetics, and those are hers. She's going to call those diabetics every 2 weeks. How are you doing? What are your sugars doing? And we'll manage those people from the office. ER intervention. You may know that if you're admitted to the hospital currently, your insurance company, your payer, determines if you are an observation patient or an admission based on criteria. And so hospitals have created observation units. They like, and it's a great business model. They want to put observation patients in one area of the hospital. Those patients should be located in one area so that they can all be treated the same. Because in the old days, bed A was an observation, bed B was an admission. Staff didn't treat them any differently. Bed A as an observation was there 3 days, bed B was there 3.5 days, and bed A, the observation, should be there 1 day. So they've created these observation units, which is a great business model. The problem is, as you increase the number of observations, you should be decreasing the number of admissions, and that didn't happen. And so we went out to the payers and we said, observations are too high. In some emergency rooms, it's too easy to move a patient from the emergency room to the observation unit. It becomes the easy button. And so what we did was we went out to the payers and we said, we're going to put a physician and a nurse in between the ER doctor and the observation unit so that we have to approve that admission to the observation unit. And you can see the data. In 9 months, we prevented 400 observation stays. These are patients headed to the observation unit who actually did not need to be there. The reason the ER was okay with this was, again, we have the outpatient schedule. We'll go into the patient's room in the ER and say, we can have you seen tomorrow morning, 9 o'clock, you've got an appointment. Or we can do a stress test as an outpatient. Or we can get that MRI as an outpatient. You don't have to go to observation. Observation is a tremendous dissatisfier for patients and for plans. For patients, it's an outpatient visit. So all of a sudden, this hits their outpatient benefits instead of inpatient. So this has been a great program for us. So what are we learning? Incentives drive behavior. And honestly, this is an indictment on the healthcare system and on physicians. I'll give you an example. If you're one of our hospitalists and you're called down to the emergency room in the past to admit a patient, you could spend the next 45 minutes doing a history and physical, put them on the floor, see them for the next 3 days, and make about $500 out of a $10,000 spend. If you went down the emergency room and you tried to send that patient home, Mr. Smith probably already left to get Mrs. Smith's slippers. It's tough to send somebody home from the emergency room once they've been told they probably need to be admitted. It takes about 2 hours to send them home, set up home care, set up home health, reconcile their medications, and that physician is paid an outpatient office call. So they're reimbursed about $75 or $80. Well, it's just easier to admit them, unless that $10,000 is yours. Now it changes everything, doesn't it? That's the doc. If you're in shared savings, and say, even if you're in a 50% shared savings, if you send that patient home, you just saved $5,000. And that's why it's an indictment on the system, because it used to be easier. Now you're in shared savings. Isn't it funny? Now we're doing what's right. So patient-centered care creates value. I think I've shown you that today. PCP burnout, primary care physician burnout, as I mentioned, in a fee-for-service world is a real issue. People don't want to go into primary care. If you have to see 25 patients a day, create a record in the electronic health record, which most doctors do at night, and manage these patients, our busiest time on our electronic health record is Saturday evening. How sad is that? Your primary care physician, he is likely on his electronic health record Saturday evening instead of at the movie with his kids or wife. So PCP burnout is real. ER utilization in Central Ohio is through the roof. It's entirely too high. Somehow we have convinced our population that if you think you're sick, you should be in the emergency room. Again, part of that's on us. That's an indictment on physicians. Because if you call your primary care physician likely at 4:30, you get an answering machine that says, if you're sick, call 911. If you're really sick, go to the ER. So we have created, physicians are responsible for some of this, and we have to address it. And that's why same-day centers, urgent cares, call centers are things we need to do for patients to keep them out of the emergency room. The other issue is few employers are looking for value. All everyone wants to know is, what's my rate next year? No one is demanding value. We should all know eventually, where should you get your hip replaced? Where is the value? Where should you, and here's the problem and this is one of the reasons we've remained independent. If every hospital system provided 20 services, exactly 20, that's all they provided, there is no way every hospital could be the best at all 20. As your primary care physicians, that's our job. We have to find out where you should be for certain procedures, and that data is coming available to us. It's very important. But employers are not seeking value. Our 2016 initiatives, we need to improve end-of-life care, and we do not do a good job at that, of having that conversation with patients. Skilled nursing facilities, and again, I applaud Mount Carmel for this. They're all over this. Our skilled nursing bed days are much too high. If you have a joint replacement, you get 21 days in a skilled nursing facility. You could go home in 10, but you stay because you were approved for 21. It's a tremendous overutilization. We need to expand ER intervention that I mentioned, the evening call centers I mentioned, and then we were involved with HealthSpot in telehealth. And HealthSpot, as you know, went under, and we were very sad about that. But we need to also, certain parts of our population, certain demographics, and likely the millennials, they want telehealth. And the truth is, they should have telehealth. There are certain conditions that should be treated via telehealth. If you're an employer, you don't need your employee downtown, leaving work, walking to the parking garage, driving to the doctor's office, and waiting 30 minutes, picking up their laundry on the way home. They're gone 3 hours. That should be a 15-minute telehealth visit from the basement of your building. And that's on us. We need to provide that for you. But it's not something employers have been looking for. That's it. Sorry to waterboard you with all this. Yes.
Why are other countries doing it for so much less than we are?
It is. So why are other countries doing it for so much less than we are? Part of it is utilization management. If you want an MRI in another country, you might wait 3 to 6 months. In Ohio, you could probably get it in the parking lot if there's a mobile unit. So part of it is utilization management. We have 85-year-olds who get joint replacements because they're still playing tennis. You don't get that in Europe. So that's part of it. Yes?
Are you being replicated across the country? If not, when are you going to start doing it?
Yeah, so are we being replicated across the country? It's a great question. It's something we struggle with. So we are being replicated. Physician organizations that are independent are forming. And there are lots of opportunities for physicians to join a system or grow to be larger. It is hard to remain independent because of trying to get to value. You can't do it as an independent physician unless you're larger. So yes, this is being replicated. Are we replicating ourselves? Right now, no. Culture is so important in this initiative. An example would be Healthcare Partners that did this really well in California. They've tried to do this in other parts of the country, and it's very difficult to replicate because the culture is so important in this. So we've actually struggled with even stretching outside of Central Ohio. We're in Lancaster, and we're looking at some other areas, but it's hard to replicate this.
Okay, thank you, Dr. Wolf.
Yep.
Yeah. Dr. Wolf, on behalf of Columbus Rotary, we've made a contribution in your name to Polio Plus, eradicating polio in the world.
Terrific.
Thank you so much for your
Thank you very much.
Rotarians, next week it's group exchange program from District 669. You talk about inspirational, that's it. We'll see you then. This meeting's adjourned.